count, differential count like this, and most of the labs are now equipped with this counters, I mean maybe automatic, semi-automatic or manual, and reports in your time would be coming in this format. So, get familiar with this type of reports. So, automated and complete blood count, this is simple at present, it has become low cost also, not very costly and available almost everywhere, and this is the person Coulter who is the basic culprit for making the change for you. And so, automated and complete blood count, pointers you need to know what are the basic errors of this. I will come into what is there in the CBC in next 1 or 2 slides. At the sample, how long you can wait before sending the sample to testing. Suppose you have drawn a slide, how long you should wait, after which or within that period you have to interpret the slide to get a proper report, right. So, RBC and platelets swell up when you keep the sample for a long time, they get damaged and their shape and size alters, giving you the false report. That is why MCV, mean corpuscular volume, it becomes high as you wait for longer period. Mean platelet volume, MPV, that also becomes high because the cell swells up, and platelet count becomes low because they get lysed by that time, like that. So, it is the 3 hours is the maximum waiting time, and for slide maximum waiting time is 1 hour, that we need to know. So, if it is hemolyzed, obviously hemolyzed means RBC is lysed, so RBC count would be low, hematocrit will be low. One very important thing you need to know this concept of MCHC would be high in hemolyzed sample. Why? Because this, when the RBC is lysed, hemoglobin remains in the plasma, and that hemoglobin is falsely interpreted by the machine within the RBC, giving high MCHC. Lipemic specimen, you know, in the blood when lipid component is much more, so this water component is less. It is simply like PCV. So, when the cellular component is more, fluid component is less. So, so similarly, if the lipemic sample, you would have less water compartment. So, that leads to falsely higher MCV. Hemoglobin would be high, MCH would be high, all would be high in. So, when there is hyperlipidemia, you have to put caution before judging that report. Cold agglutinin, again it gives false report. There are few issues, few pointers we need to know, and what are there in complete blood count. This is the investigation you need in almost every patient. Hemoglobin and hematocrit, all of you know, RBC count should be there, right, and this RBC, I had requested this pathology department here in our medical college to include distribution with them, they have done that. These are the indices that are indispensable part, these 4 you have to have. There are many more also, and as per the different programming of these counters, they have got different other parameters as well, but these are very basic parameters that has to have in almost every report. Platelet count and mean platelet volume, this is very important, and WBC count, total differential and other things. So, these CBC parameters, Menger index is an calculated parameter, it is not directly got, you do not get it directly, you calculate it. And these are known, hemoglobin, hematocrit, when you have completed physiology and part of pathology, you know these indices in the RBC, I mean hematology you have read. What is that Menger index is MCV, MCV is measured in femtoliter, MCV by RBC in millions, that is MCV by RBC in millions is called Menger index, I will come into its interpretation later on. It is a very good indicator or pointer to differentiate between iron deficiency anemia and thalassemia trait or carriers. So, this one I discussed in previous class, if you remember till now, 11, 12, 13, 12, 11 is the formula of cutoff point of anemia, right. 11 is between 6 months to 6 year, 6 year to 14 year is 12 and 13 is adult males, 12 is again non-pregnant females and pregnancy is 11. 11, 12, 13, 12, 11. Get up then get down. And on the basis of hemoglobin concentration, now you grade this anemia as mild, moderate, severe or very severe. Between the lowest cutoff point and 10 is the mild anemia on lab basis. Between the lowest point, where the lowest point is 12, that means between 12 to 10 is mild anemia. Where it is 13, 13 to 10 is mild anemia, like that. Okay. So, between 7 to 10 is the then moderate, 5 to 7 is severe and less than 5 is very severe anemia. That is how you differentiate as per laboratory basis. There are clinical criteria also that we will discuss in our during clinical classes. So, there is a mean corpuscular volume. This is one of the parameters you need to know. What is mean corpuscular volume? It is the average size of RBC, that is all. It is the average size of the RBC. Low MCV, I will come to the parameters later on. Low MCV is called microcytic. Now, you all can understand microcytic, normocytic and macrocytic. Is it clear? So, there are different parameters and according to laboratory there are variations of this MCV cutoff points, which one you will consider as microcytic and which one you will call at macrocytic. Very popular is between 80 to 100, below 80 is taken as microcytic and above 100 is taken as macrocytic. But according to lab there are variations. Say here it is given between 80 to 95. There is one formula also. This is very important because if you are given some MCQ like questions, say what is whether it is microcytic or macrocytic, this is a 5-year child. So, there you can calculate it like this, say above 84 plus 0.6 into age in year is the upper cutoff point and 70 plus age in year is the lowest cutoff point. That means, suppose a child of 5 years, you are given a MCV of 70. How, what it will be? Microcytic, normocytic or macrocytic? Child 5 years of age, MCV 70. Why? +70 plus 5, 75. So, is below 70. So, it is microcytic. So, you calculate like that. That is a easy way, dynamic, always any point you can calculate whether it is microcytic, macrocytic or normocytic, right. Newborn, this is a special class, you need to remember all the time, in newborn MCV is higher. So, macrocytic picture is newborn is physiological. Do not misinterpret macrocytic picture in newborn as abnormal. This is very important. So, it can be measured directly by automated counter or calculated by the formula like that. So, MCV can be falsely elevated in pediatrics, in adults, everywhere. This is very important one is that when there is significant hyperglycemia, severe hyperglycemia, particularly when the blood glucose level more than 600, it leads to swelling of the cell and a microcytic picture and there lysis of the cell as well, but the picture will be macrocytic, but that is false, that is pseudo. So, or presence of agglutinins like autoimmune hemolytic anemia, there also will get the same picture, but that is not a true reflection of blood picture of that patient. So, this is actually you see under microscope. I think you have seen definitely. I will just see that this slide I had shown in last class also. Black arrow here, this smaller pointers, these are indicating of platelets, and this is the our normal lymphocyte. You see, occupying the nucleus is occupying almost entire of the cell. That is one of the characters of lymphocyte, and this is the RBC. The central pallor should be 1/3 of the total diameter, that is normal. 1/3 of the total diameter is normal. If it is more, that is called increased central pallor. You define increased central pallor as the central pallor more than 1/3 of the total diameter. So, now different causes of normocytic anemia. Obviously, hemolysis initially will lead to normocytic anemia. So, it may be congenital or acquired, whatever might be. Then acute blood loss and aplastic anemia. These are very important causes of normocytic anemia. Anemia of chronic disease sometimes leads to normocytic anemia, sometimes it is called dimorphic anemia, because chronic disease leads to nutritional deficiency as well. So, it gives picture of the both. Microcytic anemia, this is you are conversant with. Iron deficiency, that is the commonest type of anemia in our country. Thalassaemic syndromes, baby trait measure or whatever might be, and anemia of chronic inflammation, lead poisoning, sideroblastic anemia, all this leads to microcytic anemia, and this is one, this list you have to memorize, right, because this is one question anytime in clinics you may be asked, what are the other causes of microcytic anemia? This is very common question. This is another very common list you need to remember. I have made it very short for you so that you can remember it very clearly. So, with megaloblastic bone marrow and without megaloblastic bone marrow. With megaloblastic bone marrow, that is a true macrocytic anemia, that it happens in vitamin B12 or folate deficiency only. But all others, aplastic anemia, Diamond-Blackfan syndrome and all these other conditions where you get macrocytic peripheral blood picture, bone marrow remains normal, or bone marrow otherwise indicates disease like Diamond-Blackfan syndrome, that is pure red cell aplasia. There you get different blood picture, but it is not macrocytic. So, here MCB again same thing I have told. There is a slightly enlarged picture. I will show you what is other things. This MCH, mean corpuscular hemoglobin, is the average amount of hemoglobin present in one RBC. You will see MCH and MCHC are very close terms. So, MCH is the average amount of RBC, hemoglobin present per RBC average, and that is why its unit is picogram. That is why its unit is picogram and average value is 27 to 31. Again hyperlipidemia results in spuriously increased reading by counter, giving rise to high MCH. MCHC is the average weight of hemoglobin per unit volume. So, if it is microcytic anemia, sometimes MCHC may be higher. Suppose you get one RBC, suppose this is the ball size RBC. Now, some part of the plasma membrane, membrane of the RBC is lost and you stitch it up. So, it becomes a smaller ball, right, but the hemoglobin concentration remains the same. So, what will happen to MCHC? Per unit volume, MCHC will be higher. That happens in spherocytosis, because in periphery in the spleen there is lysis of the cell in spherocytosis and some RBC are regenerated, that leads to spuriously higher MCHC, and that is one of the screening tests for spherocytosis as well. So, MCHC would be high in spherocytosis. So, hyperchemia you call when MCHC is, so MCHC is the percentage is less than 28 and more than 36 is called hyperchromia. So, high MCHC occurs in a hereditary spherocytosis. It may be in case of severe burns or liver disease or sickle cell, and low MCHC would be found in iron deficiency anemia, lead poisoning, thalassemia syndrome, again the same list, almost same list of microcytosis, right, and spuriously high in hyperlipidemia, hyperbilirubinemia, auto-agglutination antibodies, right. When you are interpreting the report, you have to keep in mind why, if there is any abnormality or discrepancy either with the clinical picture or with the other parameters of the CBC, you have to think why this is so, then these questions will come, right. So, red cell distribution width, this is very, very important criteria. Previously, it used to be calculated as whether it is microcytic, macrocytic or normocytic, then what is the MCH. MCHC previously used to be taken as more sensitive criteria than MCH, but later on it was found there are some fallacies. So, red cell distribution width came, it is a marker of anisocytosis, that is different size, different cell lines, one having 70 femtoliter, one having 80, one having 90, that is called anisocytosis. But all the red cells, if it is 70 or 75 or 80 similar, so it is the iso, same cell size. So, different cell size is called anisocytosis and the marker is red cell distribution width. So, what is the distribution width? Lowest to highest. So, lowest cell size to highest cell size, that is the range of RDW. So, RDW is measured in two ways, one is coefficient of variation. I am not showing you the graph or the bar diagram which is there behind this calculation, that is not needed for you right now, and one is for standard deviation. So, in report you will see maybe RDW CV, RDW SD. So, do not confuse with either of these two. SD is the actual measurement of the cell and CV is the calculated value. So, high RDW helps again in distinguishing nutritional anemia, which may be either iron deficiency, folate deficiency or B12 deficiency, all will have high RDW. RDW would be increased, but you can highly differentiate between iron deficiency and B12 and folate, because they will produce macrocytosis and this will produce microcytosis very easily. And it again distinguishes between iron deficiency and heterozygous thalassemia, I mean carrier or trait, whatever you may call it, and it can distinguish between B12 and folate with other causes of macrocytosis, as I told you. So, this is RDW is a very important criteria. Usually CV is taken as there are different lab variations again. You see in the very one pertinent point is that in every report you have to see what the laboratory is giving as the reference range, but that you have to accept. Do not put your academy first there, the lab the very reference would be the coming first. So, here normal range is between 11 to 14.5 and MCV 80 to 100, that is the lab reference. Based on that, if RDW is normal and low MCV, it is called thalassemia, and both are normal, so there is no anemia, and high MCV, the macrocytosis, that happens in aplastic anemia. So, in aplastic anemia you will have macrocytosis. If RDW is high and MCV is low, it is iron deficiency. So, in iron deficiency and thalassemia both will have low, both will have low what? Low, speak loudly, bit louder, low MCV. So, thalassemia and IDA both will have low MCV, but in here RDW would be normal and RDW would be high in iron deficiency. So, that helps you to differentiate between a thalassemia trait and iron deficiency anemia. There are few other parameters that will be coming up, and when you will enter in your clinical practice, this will be most likely very common investigation because of thanks to this hemoglobin concentration, and there are few more in the platelets, mean platelet volume, large platelet, giant platelets, and like red cell distribution width, you will have platelet distribution width PDW as well, and immature platelet fraction or IPF. I will come one or two lines on each of these later. So, this is reticulocyte count. It is stained by a supravital stain. Why it is called supravital? Because the stains cells are stained in living condition. So, that is why it is called supravital. So, now when you stain them in methylene blue or Romanowski stain, what happens? They show remnants of this RNA in a reticulin pattern. That is why they are called reticulocytes. That is the reason why they are called reticulocytes. So, there again corrected reticulocyte, there are different RPI, reticulocyte index. So, these are different indices that should come in reticulocyte. This is macrocytic polychromic cells in smear. Polychromasia refers to macrocytosis, right, and bluish tinge due to presence of RNA. So, these are actually very early stages of RBC. What is earlier stages of RBC? That is called reticulocytes, right? So, they mature and they turn into the RBC, mature RBC. So, what are the causes of reticulocytosis? Any cause of stress, any cause of stress to the bone marrow which is functionally active will lead to reticulocytosis. So, any severe anemia will lead to reticulocytosis after few days. Hemolytic anemia, any stress, acute hemorrhage or even in the recovery stage of anemia, late pregnancy, high altitude, that leads to hypoxia leading to bone marrow stimulation. So, they will lead to high reticulocyte count. This is how it is calculated, not very important for all of you to know. Absolute reticulocyte count is the absolute or count of that. It is usually reticulocyte count is given in percentage of RBC, and this is the total number of reticulocytes present in the blood. Corrected reticulocyte count is 1, say when the bone marrow is in stress to release more RBC because of anemia, because of hemolysis, because maybe a recovery stage of iron deficiency anemia, like that, whatever might be. When they are in stress, they release more and more RBCs. When batches of RBCs are released very rapidly, what happens? More reticulocytes also enter into the blood, but that is not the true reticulocyte count of that patient. So, that needs some certain correction. That corrected value is called corrected reticulocyte count. More than 3% is generally indicative of hemolytic anemia, or actually it is not hemolytic anemia, it is stress to the bone marrow. That is why I said more reticulocytes enter into the blood when bone marrow is in stress. So, that leads to higher RPI. So, RPI more than 3, usually many of the textbooks you will see reticulocyte count more than 2.5% indicate hemolysis. Here they have given 3 as the figure. So, increased reticulocyte count, this is again stress to the bone marrow. This basic thing you need to remember, it may be due to hemolysis, it may be due to hemoglobinopathies that leads to de novo hemolysis within the cell, within the body, then sickle, then membrane defect, and these are different causes of hemolysis. I think you now can remember the etiology of hemolysis, pathies. Can you tell me 3 pathies of hemolysis? Membranopathy, morphological defect, membranopathy, enzymopathy, তাই তো? enzymopathy তে মনে আছে কি কি আছে? Can anybody tell me one example of enzymopathy that leads to hemolysis? Yes? Yes? G6PD, with G6PD, pyruvate kinase, so these are enzymopathies. So post hemorrhage again it increases after 3 to 4 days after treating of iron deficiency anemia. These are the different stress conditions when bone marrow releases more and more reticulocytes. Decreased, that means bone marrow activity has to slow down to decrease reticulocyte count. Bone marrow activity has to slow down or RBC fragment, precursor should be less, as happens in diamond blackfan and this syndrome. So aplastic anemia, which may be congenital or acquired, myelodysplastic syndromes, bone marrow infiltration, all this leads to decreased reti counts. IRF এগুলো বলছিলাম বলবো, immature reticulocyte fraction. Actually within that reticulocyte count, Coulter can identify the reticulocytes which are still earlier, still nascent, primitive. So any stress or anything will lead to first change in that fraction, immature fraction. So that is more sensitive to change in body milieu. So that is called immature reticulocyte fraction or IRF. Normal value of this is fragmented red cell, normal value is 1 to 7%. IRF normal value is not given here, it is 1 to 7%. So fragmented red cell or cystocytes, it indicative of hemolysis, and microangiopathies, a normal range is 0.03 to 0.5 or 0.6. Fractional iron deficiency, iron stores are normal or even high, but iron is not delivered. You know, for iron utilization you need a protein produced by the liver and that is called hepcidin. So when the hepcidin is more, iron transport is inhibited, vice versa, it acts reciprocally. So that is inappropriate hepcidin will lead to body will have iron, but body will not be able to utilize iron because the transport protein deficiency. Reticulocyte hemoglobin, again the hemoglobin content of the reticulocyte, a reference value is 28 to 30 picogram. You just remember the names at least, and immature granulocytes. This is important when you screen a patient for infection. That is usually called, there are many things, Dole bodies and these things, but they are not consistent. What is consistent is the IT ratio, what is called band percentage, right. So band is the immature or earlier version of the matured lymphocytes, neutrophils. So it is the ratio of the thinnest part of the nucleus. I will show the picture in the next slide. Between the thinnest part and the thickest part should not be more than 1/3. So that we will call band. When it is a mature neutrophil, it will be much more. One part will be very thin and another one is very thick. So the ratio would be much higher. And this is important, you need to remember, if neutrophil with lobes, nuclear lobes more than 6, it is called hypersegmentation. When it is 5 or lobes are 5, then to classify as hypersegmentation, it has to be 5% of the total count. So 5 lobes 5%, 6 lobe no percent. So that is called hypersegmentation. So this is the picture you see, this is a band, you see the nucleus, it is almost homogeneous, right. And you see here, see the constriction and see the breadth. So this is the mature neutrophil. So that is the difference between band and mature neutrophil. Now, if the segmentation is more, you see here how many segments are there? 1, 2, 3, 4, 5, maybe 5. So, if you got 5, then at least 5% should be there of the total neutrophil count to classify that as hypersegmentation. If it is 6, then no percentage. So, this are the parameters we are speaking of. This is the average value. Different age groups it is given term, then month wise, and this is in 6 to 12 years. So, I have given you the cutoff point of anemia also, and you need to remember these values actually, this MCV, MCH, and these are the things, right. Now, again coming back is the classification of anemia. Now, microcytic hypochromic. Previously, I had given microcytic, macrocytic and normocytic. Now, it is microcytic hypochromic anemia. This list you have to remember: iron deficiency, thalassemia, chronic inflammation, chronic disease, lead poisoning, copper deficiency and sideroblastic anemia. This you have to remember. Then normocytic with high reti counts and low reti count. High reti count occurs in spherocytosis, elliptocytosis, all these causes of this hemolysis. This is morphological defect and this is the defect in the shape, and this is the G6PD enzymopathies. And low reti count, obviously bone marrow activity would be low, as happens in aplasia, blood loss. This is important for pediatrics, you will not get in adults. This is called TEC, that is transient erythroblastopenia of childhood. Transient erythroblastopenia of childhood, it is transient, as do not remember, but during that period it shows a picture of aplastic anemia. Diamond Blackfan syndrome, you know, this is a pure red cell aplasia. Macrocytosis, again B12 and folate would come first, and third list in the list would be aplastic anemia. And then it's the liver disease, alcoholism, and MDS is myelodysplastic syndromes. Do you like to do some homework? Yes, okay. So, this is a 9-month girl, exclusively breastfed. Why the term exclusively breastfed is given? Because if it is top fed or fed with the cow's milk, whatever, or tin milk, whatever might be, it leads to chronic hemolysis, blood loss. That leads to anemia. So, exclusively breastfed presents with pallor, 9-month child, and blood picture is given as hemoglobin 6.4. Is it anemic? First question. Is it anemic? Say yes, no. you will be needing in every